guidelines in order to use the CAM-ICU as a tool for determining delirium. Both of these tools have been validated in critically ill patients, and both of these tools are used in determination of delirium in the critically ill patient. So in 2008, there was a group of people that got together to understand the meaning of the terminology delirium. Because as more and more literature got published in multiple languages, it became clear that people were not necessarily using the diagnosis in a unified manner. So there was a conflict in the terminology as well as the phenomenology of delirium. And some physicians were using the diagnosis delirium entirely based on the DSM criteria for delirium. As long as the patient met those criteria, then they called the patient as being delirious, while others only diagnosed it when the etiology was unknown. That means that if there was a specific diagnosis, for instance, drug or alcohol withdrawal, or symptoms occurred in the context of a history of such drug or alcohol use, then they only diagnosed it if they understood that there wasn't an underlying lesion. So this became very confusing, and that's why there was an effort to understand what exactly delirium means. So the classification as we know it is based on psychomotor subtypes. There's hyperactive delirium, which is so easy to diagnose. The patient is agitated, they're trying to get out of bed, they're not making any sense when you're talking to them, then that clearly fits into the category of hyperactive delirium. Then you have hypoactive delirium, or the quiet delirium, where there's reduced psychomotor behavior and lethargy. So these are, in my world, in the neurological world, we refer to these patients as being encephalopathic, because they're drowsy, they're not really following what we're asking them to do. But by definition, in the classification as defined in 2014, that is hypoactive delirium. Then you can also have the mixed delirium, where you have hyperactive and hypoactive manifestations, and it fluctuates throughout the day or over the course of several days. And last and final, there's subsyndromal delirium, where you find symptoms of delirium, which is inattention, disorganized thinking, anxiety, irritability, but they don't fully progress to meet the diagnostic criteria as defined by Dsm-5. So the goal was to unify the term delirium if patients met all of the criteria based on the Dsm-5. And the Dsm-5 criteria included a disturbance of consciousness, alteration of cognition, which includes memory, orientation, language disturbance, or perceptual disturbance, and a disturbance that develops over hours or days. And this is very important, because in order to define delirium, it really has to develop over hours or days, and it has to fluctuate. So this criteria was clearly established in 2014. And criteria D is that there is evidence of an etiological cause. And the goal of making this definition very clear was to avoid the pitfalls of having different terms to describe the same syndrome. And in this classification, they put encephalopathy into the diagnosis, into the broad umbrella of delirium, and they refer to encephalopathy when somebody had a hypoactive subtype. Acute mental static changes or hallucinations can occur in isolation. If they did not have other diagnostic features of delirium, then it was called a subsyndromal delirium state. So just to summarize that, because this can become very confusing, everything falls under the bucket of delirium, and encephalopathy also falls under the bucket of delirium. What DSM-4 did not account for is patients who have underlying dementia or psychiatric problems, and it also did not account for coma. So this is how it fell into two categories. So you either have delirium or you have coma. And those patients that, which is in the dotted line, if you have hallucinations, delusions, or illusions, and you don't clearly meet the other category of delirium, then they fell into their own category or a subcategory of delirium, not fully meeting the DSM-4 criteria. Now, to talk a little bit about encephalopathy. Encephalopathy is a dysfunction of the level or content of consciousness, and it is related to brain dysfunction. And it's generally related to global brain insult, or it can be a focal lesion that causes encephalopathy. The key feature is that there has to be a predominant cognitive component. However, it can range from disorientation all the way to coma, and in between you can get somnolence, lethargy, and stupor. And it's actually more a clinical state than a disease entity. And one of the key things that one needs to understand about encephalopathy is that it's a more slower course, in that it is not hyperacute like delirium, but more subacute. And it is related to underlying physiologic and a systemic derangement. Now, over and above having the acute mental status changes, you can also get additional features like myoclonus, seizures, nystagmus, muscle rigidity, tremors, asterixis, all of which then falls into the category of encephalopathy. So it is important to recognize that encephalopathy can be caused both by a primary neurological illness as well as a systemic illness. Generally speaking, the etiology is probably multifactorial, and pathways by which the systemic disease or toxins lead to encephalopathy are poorly understood. But in patients that develop encephalopathy, the belief is that the blood-brain barrier is affected, that it's disrupted, and that is an essential contributing factor to the development of encephalopathy. What happens when the blood-brain barrier is disrupted is that toxins can enter and accumulate in the brain, and most importantly, it affects the ascending reticular activating system, which leads to alterations in the brain neurochemistry, leading to decline in awareness and arousal. And it can also, within the brain, what it can cause is cerebral edema, as we spoke about the neurotransmitter levels that are affected, which then in turn leads to impairment in the neuronal membrane excitability, and thus leads to a decrease in mental status. Now, in patients with neurological injury to begin with, they already have a pre-existing disruption of the blood-brain barrier, which then facilitates the entry of the toxins into the central nervous system. So in these patients who already have brain injury, the toxins, as you can imagine, can enter the brain much more significantly, can linger in the central nervous system longer, and therefore encephalopathy can be more profound and have a more severe and prolonged course. And this is just a diagrammatic representation of how the reticular activating system connects with the thalamus and the cortex and vice versa. And it is the key area affected is the brainstem reticular formation, which then ultimately leads to the changes in the mental status. So in 2020, this publication came out, and this is the updated nomenclature of delirium and acute encephalopathy. And there were 10 societies that came together to publish this paper. And the most important reason for this publication was the fact that there seemed to be still, despite the Dsm-5 criteria, so much of confusion about who has delirium, and should I say, when do you call it delirium, and when do you call it encephalopathy? So patients with an acute illness frequently acquire an acute global disturbance in cognition. And it has been called delirium, encephalopathy, acute confusional state, acute brain dysfunction, acute brain failure, and altered mental status. And do all of these terms mean the same thing? And the answer is perhaps. So encephalopathy more broadly encompasses mental status changes, which is due to focal or global brain insult. And that definition has already been well stated. And it is encephalopathy is most commonly used to describe a global brain insult. And with this, in this publication, they switched and said delirium is a subtype of encephalopathy, where patients develop acutely altered mental status and there's waxing and waning of the attention. So we moved from the DSM-4 criteria where everything fell under the umbrella of delirium, including encephalopathy, which was a subtype of delirium, to now delirium becoming a subtype of encephalopathy. Now, just a little bit about acute encephalopathy. There are many reasons why patients can develop encephalopathy. It can be a primary neurological cause, which can be vascular, seizure, migraine, trauma. So the spectrum can range from hyperacute to more chronic reasons. And the chronic reasons are, again, can be degenerative, normal pressure hydrocephalus, or even those indolent infections like syphilis or HIV-associated neurocognitive diseases. Now, with the systemic, that includes toxic, metabolic, drug-related, psychiatric, as well as things like hypertensive encephalopathy and more chronic conditions like heart failure, endocrinopathy, malignancy, autoimmune, obstructive sleep apnea. So there's a whole spectrum of disorders that can cause a patient to present with encephalopathy. So it is progressing. When we say that, what we mean is that it can usually several hours to a few days, but by definition, it has to be less than 4 weeks. And it's a pathobiological process that's occurring in the brain. And it can lead to clinical presentation. You can get subsyndromal delirium, you can get delirium, and you can also get coma. So that's why the term now, the Dsm-5 criteria, which we're going to get into in just a second, now said that acute or encephalopathy is probably the better terminology under which delirium becomes a subtype, because all of these represent a change from baseline cognitive status. So here's the DSM-5 criteria. You have to have a disturbance in attention, which develops over a short period of time and is an acute change from baseline attention and awareness. In addition, you get a disturbance in cognition. And these are not better explained by a pre-existing, established, or evolving neurocognitive disorder and does not occur in the context of a severely reduced level of arousal, such as coma. So, finally, we have started to acknowledge that coma cannot be included into the spectrum of acute encephalopathy and delirium specifically. There has to be evidence from history, physical examination, or laboratory findings that it's a direct physiological consequence of another medical condition, including substance intoxication. So delirium is a clinical state that is characterized by a combination of features as defined by the DSM-5. Now, to take a minute to talk about coma, it is a clinical state of severely depressed responsiveness, and it is defined by a diagnostic system, and most commonly what we use is the GCS, or the Glasgow Coma Score. And subsyndromal delirium is an acute cognitive change that is compatible with delirium, but does not fulfill all of the DSM-5 delirium criteria. Still confusing, because can subsyndromal delirium be defined as acute encephalopathy? Sure, that's a possibility, but it definitely isn't coma. Now, where this starts getting confusing to people like me, we are neurologists, is the fact that there's so much of additional information now available about what is happening in the brain during sepsis. So this article deals with the bacterial dissemination during sepsis, and sepsis-associated encephalopathy is actually a result of the fact that you have infection also involving the brain. So in patients who have encephalopathy as a result of sepsis, do you need to rule out brain infection? And if they end up having a CSF that is consistent with an infection, then do you need to reconsider the duration of antibiotic therapy who have developed a brain dysfunction? And this article also raises semantic issues Like, should we be calling this sepsis-associated encephalopathy, or should you be calling it sepsis-associated encephalitis? And in my world, I would rather call it an encephalitis than an encephalopathy, but of course proving that there is a secondary infection in the brain. And then we have this article that talks about cerebral autoregulation and the fact that in patients who have sepsis, that brain dysfunction could be related to alteration in cerebral autoregulation. And when I say cerebral autoregulation, we're talking about the ability of the cerebral vasculature to affect the blood flow to the brain. And we know that very often in sepsis, you get drops in blood pressure. You have, it fluctuates, and depending on how quickly you respond to it, it can affect the brain. The blood flow to the brain is definitely affected. So if that is the case, then should we be saying that this is a sepsis-associated encephalopathy, or is this a sepsis-associated cerebral dysfunction of autoregulation? And here's another publication talking about the sepsis-associated encephalopathy and everything that goes wrong in the brain as a result of that. So we have seen multiple ischemic strokes develop in patients with sepsis. You can see vasogenic and cytotoxic edema. You can get PRES, or posterior reversible encephalopathy syndrome, where you get edema in the cortical, occipital lobes, parietal lobes. You can see hyperintensities in the basal ganglia and thalamus. You can also get cortical hypodensities and ring formation, as well as areas of focal hemorrhage. And all of this is related to multiple factors that you can get because of hypotension-related microcirculatory dysfunction. There can be coagulopathy. There's endothelial activation, microthrombosis, blood-brain barrier breakdown, as well as you can get cerebritis and microabscess formation. So this then leads to even further understanding of what is happening in the brain as a result of sepsis, and then do we specifically name the etiology of the encephalopathy as opposed to calling it just sepsis-associated encephalopathy? I had the privilege of working with the group that has published just about everything in encephalopathy, which is Dr. Wasili and his group. And we looked at delirium monitoring in neurocritically ill patients and did a systematic review of whether delirium is even a possible diagnosis. We were also a part of the ABCDF bundle from the Critical Care Society of Critical Care Medicine, and we were the only neuro-ICU in the United States that participated in this study. So we looked at a total of 1,173 patients in a neurologically critically ill situation, and we looked at the diagnosis of delirium in these patient population. And what we were able to demonstrate is that patients with a primary neurological diagnosis can meet criteria for delirium. And delirious features can actually predict relevant untoward clinical outcomes. So this article, which was published in 2020, talks about delirium screening in the critical care and stroke unit patients. And this is a pilot study that looked at the neurological deficits and how it influenced CAM-ICU and ICDSC. What they found is that a positive delirium screen with both CAM-ICU and ICDSC in neurocritical care and stroke units was found to be significantly associated with the presence of neurological deficits. And let me explain that a little better. What that means is that many patients who are admitted to a neurological ICU have impaired consciousness, can have expressive aphasia, can have impairment of language comprehension, and can have hemi-neglect. And all of these impact our ability to grade in CAM-ICU and ICDSC. So many patients who tested positive for these screening tools actually had primary neurological deficits from the brain injury that they presented with. So what this article ultimately concluded is that in a neurological patient population, you need screening tools that are a little bit more specific than the CAM-ICU and the ICD-SC. Because the sensitivity in our patient population with the CAM-ICU is low, it's about 66.9, not really that different from the ICD-SC, which looked like it might be slightly superior than the CAM-ICU in detecting delirium in this patient population. And standard delirium screening tools validated in non-neurological settings actually are not reliable in patients with neurological deficits. And most importantly, impaired consciousness has the greatest influence, followed by language comprehension difficulties, as well as time neglect, in making this poor diagnostic tools in a neuro ICU. So this is my own publication. I'm sorry, it's not yet a publication, but that's what we're working on. This is unpublished data. So for the last several years, we have been documenting both CAM-ICU and ICD-SC, as well as the Dsm-5 criteria that the attending physicians use for every individual patient that's admitted to the neuro ICU. And we have, because we believe that ICD-SC is perhaps a superior screening tool for a neurological patient. We excluded patients that have drug or alcohol-related withdrawal, a history of dementia, or coma, and the patients actually had to be in the hospital for at least, or in the ICU for at least 72 hours before we included them in the study. So we had about 206 patients and 1,442 assessments that used one of the screening tools for determining whether they are delirium or not. And what we found is that true delirium prevalence was about 1.6% when we compared the CAM-ICU, the ICD-SC, and Dsm-5. But we also had the same findings as in the previous publication, that perhaps the ICD-SC is a slightly better tool in determining delirium in the neurologically ill patient. It performs slightly better than the CAM-ICU, though we found no correlation between CAM-ICU, the ICD-SC, and the Dsm-5 in together when we looked at it, but more with Dsm-5 and ICD-SC. So last and final, let's talk a little bit about the treatment of delirium. This is unfortunately the publication that shows that IV Haldol as well as ziprasidone as compared with placebo in patients, but not in a neurological ICU, but patients who have respiratory failure, shock, or hypoactive or hyperactive delirium in the ICU, the use of these medications did not significantly alter the duration of delirium. That does not mean that we shouldn't use it if the need arises. It definitely helps the management of the patient in an acute setting. What we do know is that we should not be using benzodiazepines because they compound and perhaps make delirium worse. And the biggest role for management in ICU is perhaps trying to normalize the environment as much as possible for these patients. Limit the interventions, try to, give them proper sleep, keep the daylight lights on during the daytime so that they can understand the difference between day and night. Try to normalize the environment with regards to family members being available to ease with their anxiety, and also getting patients out of the bed, having them maybe walk if they can walk the unit, participate in physical therapy and occupational therapy, and if also trying to get them to keep their hands active, maybe make them do little tasks that will help them focus their abilities on doing something constructive. As such, medications are, again, only useful. We do use Haldol and Zyprexa in patients who are hyperactive because we definitely do not want them to hurt themselves. And we want to be able to control the environment that these patients are in because they need the treatments that are helping them get through their systemic illness that has gotten them into the hospital to begin with. That is the end of my talk. I appreciate your time, and I'm happy to take any questions if we have the time to do so.